Good evening, everyone. You are welcome to this session of general surgery presentation, where Dr. Samuel is going to be discussing on the principles of Bowel anastomosis. Principles of Bowel anastomosis is an important aspect in general surgery, where all residents as well as senior registrars need to be very conversant with the aspect, because anastomosis is something that you encounter during emergency cases as well as elective cases, and is one of the techniques that a resident should be very conversant with. In fact, in dry labs, you go to some dry labs where techniques for improving your basic surgical skills will involve giving you a lot of anastomosis to run, irrespective of the specialty you are in surgery. So certain dry lab programs, you will be given some intestine, maybe pig intestine or from sheep to anastomose, and you will be examined to see if you follow the principles. So it is very important that you understand all the principles behind this. So we are going to be listening to Dr. Samuel. Afterwards, we will now make our observations, comments, and corrections, and questions, of course, which will have another session where he's to answer all our questions and all our observations that are raised. So, Dr. Sam, you can go ahead and commence your presentation. Thank you. Dr. Sam, we can't hear you. Can you unmute yourself and commence the presentation?
Okay, I'm sorry about that. Good evening, all. Today we are going to be talking about principles of bowel anastomosis in surgery. I'm going to be using this outline. It's going to run through from the introduction to the types and then the indications for anastomosis down through to conclusion, and then references used for the presentation. By way of introduction, anastomosis in surgery essentially means connection of two body channels together, such as parts of the intestine or blood vessels. That is connection between two passageways of whatever contents these passageways procure. The word anastomosis comes from the Greek word ana, which means without, and stoma, which means a mouth. So this is when a tubular viscous, that's bowel, is joined after resection or bypass without exteriorization with the stomach. So it's joined without a mouth. So that is the means by the nomenclature in which anastomosis was coined. So intestinal anastomosis is the surgical connection of two separate or severed bowel to form a continuous channel. Now, it is one of the most common types of anastomotic procedures carried out in surgical practice. Now, the types of anastomosis, there are different ways in which they could be classified, based on the technique used in the anastomosis, which might be hand-sewed or the stapling technique. It might be based on the orientation of the bowel that's anastomosed. That is, if it is the cut ends are being anastomosed, it's this end-to-end anastomosis. If it's the sides of the bowels that are going to be approximated together and anastomosis, that's the side-to-side anastomosis. And if it's an end of a bowel to the side of another bowel, then it's referred to as the side end-to-side or side-to-end anastomosis. This is just a pictographic representation of this anastomosis. We have the end-to-end anastomosis in the A picture, and then we have the end-to-side anastomosis in the B picture, and then we have the side-to-side anastomosis using the linear stapling technique in the C picture. Now, also continuation of the type. So based on the part of the bowel involved, it could also be classified as the gastrojejunectomy, ileocolic anastomosis, ileoanal anastomosis, colocolic anastomosis, coloanal anastomosis. Now, based on the number of layers that are approximated of the bowel, it could be a single layer anastomosis or a double layer anastomosis. Now, the various indications in which why we carry out bowel anastomosis include restoration of bowel continuity following resection for gangrene, for whatever the cause of the gangrene might have been, in intestinal perforation, malignancy, both primary malignancy or benign conditions such as polyps or intestinal obstructions, also from strictures. These are all indications for resection and bowel anastomosis. Also, we could do anastomosis to bypass unresectable bowel diseases, such as advanced tumor or metastasis causing some form of intestinal lumen obstruction. Also, intestinal anastomosis is also carried out in some congenital abnormalities, especially seen in intestinal atresia, when there is failure of canalization, recanalization of the bowel, as seen in neonates, and you have to do resection anastomosis to bypass the intestinal segments that did not recanalize. And then we have the Hirschsprung's disease, the absence of colonic ganglion cells. So to resect the parts without the ganglion cells and anastomosed bowel. So these are the various indications, some of the indications that necessitate bowel resection and anastomosis. Now, in bowel resection and anastomosis, it's also the principles involves the preoperative preparation for this patient, intraoperative, and then the postoperative preparation, management of this patient. The preoperative preparation of this patient, in which you plan to carry out either an emergency resection anastomosis or an elective one, is very important because this is a guide to significantly bolster your outcome and prevent complication. So it's quite important that you know that there are various factors in the preoperative stage of a patient that have to be looked at optimally and optimized properly before going in for your procedure. And as usual, we always start with our resuscitation, whatever, addressing immediate life-threatening conditions, or adequate rehydration, and the optimization. So if the patient presents with severe dehydration, because these factors will significantly influence our anastomosis. So we want to properly rehydrate them. If they are anemic, usually if it's PCV less than 11 milligrams per DL, you want to transfuse them. If there's infection, you want to commence them on antibiotics. And if they are malnourished, you want to optimize their nutritional status, preferably by oral administration of diets prior to you carrying out the procedure. That is if it's an emergency elective procedure. But if it's emergency, then you might have to cut short that. And then for elective cases, bowel preparation also has been advocated, especially chemical bowel preparation. Preparation has been advocated to actually significantly improve outcome of intestinal anastomosis. Also, antibiotic prophylaxis preoperatively is also advocated to improve outcome, and then counseling of the patient on the fact that they'll be on NILPA for a particular duration immediately post-op, and because their cooperation is also important for adequate outcome. Now, intraoperatively, there are various factors we actually have to try to see that they are imbibed to ensure good outcome. Now, we'll start with the anesthesia. GA is preferred because this offers good muscle relaxation to make sure the muscles are relaxed and are not opposed under tension. Good optimal blood pressure is throughout the period of anastomosis to ensure good tissue perfusion, as the edges that you are resecting is important because absence of blood will cause some form of ischemia and will ultimately affect your anastomosis. And good optimal blood pressure counteracts that with providing the necessary nutrients for the edges. Now, adequate access and exposure to ensure that you have adequate access and exposure, proper lighting of your field so that you can see everything you're doing. And then as assessment of the viability of the cut ends, typically, this is what we typically do. The cut ends are always observed for bleeding, fresh blood, bright red blood. This tells us that, okay, the ends are viable. As if the ends are not viable, that's actually a contraindication to anastomosing the bowel. So also, another principle that is quite important is, as much as possible, avoid clamping the mesenteric vessels, especially using a crushing device. So it's advocated if you actually have to clamp the cut edges so as to prevent spillage and contamination of your upside. A non-crushing clamp is advocated to be used. However, you do try not to clamp the mesentery. At no point in time should you clamp the mesentery. Then, also, it's advocated that intraoperatively, bowel decompression has been noted to significantly improve outcome of Bowel decompression has been noted to significantly improve outcome, as this will, in the post-operative period, the stress on the guts will actually be less and therefore promotes healing of the guts. So in the technique to be used in bowel anastomosis, the meticulous technique, the techniques in which is advocated to be used is that the line of transection, that's the edges that you're going to be resecting, is advocated that is not cut perpendicularly, is cut in an oblique fashion, that is towards the anti-mesenteric borders from the mesenteric borders. And then before you start your anastomosis, space sutures are typically applied as a guide at the mesenteric and the anti-mesenteric borders. And then before you start, you have to have it at your mind that it should be a tension-free apposition of the edges so as to prevent strangulation of the cut edges and promote healing. And then the appropriate use of the appropriate sutures is also important. It's usually recommended to use, we typically use the Vicryl 2.0 and 3.0. In the past, depending on the type of suturing technique, catgut and silk had been used. But currently, we typically use the Vicryl 2.0 and 3.0 non-traumatic needles, that's the round body needle. And then while approximating the edges, inverting the edges is advocated, as this helps in ensuring a tight anastomosis as well as promoting healing and hemostasis. Also, the resection margins should be adequate, so all pathologic ends should be resected, as anastomosing a pathologic end will affect your outcome of anastomosis. Also, ensuring patency and avoiding narrowing of the lumen is also advocated. Also, when the cut edges are not of the same size, you might have to carry out various maneuvers to try to evade this. That's such as cheating or chittling, or sometimes the side to end or side to side anastomosis might be advocated. Also, after your anastomosis, it's advocated that you close the mesenteric defect so as to prevent internal hernias and also promote surgical recovery. Also, usually, it's also advocated sometimes to put a drain to protect your anastomosis from spillage. This is typically done for pelvic anastomosis. Also, intraoperatively, the choice of your anastomosis technique, either the single layer anastomosis, which typically involves an interrupted seromuscular suture, usually the absorbable thread, and the seromuscular is quite important that you also, in your anastomosis, if you are doing a single layer anastomosis, is important. You know, there are different layers of the intestine running through from the outside inside. We have the serosa, the longitudinal muscle, the circular muscle, the submucosa, and then the mucosa. So it's important that you pick also from outside the seromuscular. You are also picking the submucosa, as it's well vascularized, and it's picking it improves the outcome of your anastomosis, and it's very important because the blood supply is largely in the submucosa. Examples of this single layer we could be seen using the lumbar stitch, which goes through the layers and the seromuscular layer. And this is an example, a pictographic example of the single layer technique. Using the one seromuscular layer, you can see the stay stitch applied, and then the single layer at the other side has been apposed, and then the other side is being apposed. Then intraoperatively, you can choose to use the double layer anastomotic technique, and typically it involves an inner continuous absorbable layer, which involves stitching all layers of the bowel loop, starting from the outside to the seromuscular and then to the submucosa and the mucosa. Usually, it's been advocated used to be utilizing an absorbable suture for the continuous and non-absorbable suture for the seromuscular layer to cover the first layer. This is advocated that it provides better structural integrity for your anastomosis. However, there are advocates for and against this. Now, also serosal position and mucosal inversion of the inner layer has an added advantage of the hemostatic effect. So that inner continuous layer has the hemostatic effect. However, the mucosa is strangulated. Example of this we can see is using the cornel stitching technique. This is an example of the first layer picking through and through, and then using the continuous layer for the first layer. Initially, you put your two stay stitches at the mesenteric and anti-mesenteric borders. You go through and through a continuous layer, and then after that, you come out again to reoppose the seromuscular layer to serve as to further invert the edges. This is just a pictographic representation of the various stages involved. From number one, we can see the application of the two stay stitches. After that, you start the continuous inner layer of stitch application, and then it goes through, and then after that, the seromuscular layer, and then in the tent, you can see them demonstrating the donut sign, which tells us about luminal patency. Who gives us a guide about the luminal patency? It's the same thing here. And then intraoperatively, we can also use either the hand technique or the stapling technique. Now, for the stapling technique, there are devices which have been seen to help reduce operative time. And the outcome, both the sewing and the stapling techniques have been seen to be very comparable. However, this has the added advantage of the fact that its significant operating time will be reduced. And then there are majorly two types, the linear and then the circular. And then there's another one to sew cut bowels. So this linear stapling device typically is used for the side-to-side anastomosis, while the circular stapling device can be used for an end-to-end anastomosis. And then this is the example of the devices. The first one is the circular stapling device, typically used for end-to-end bowel anastomosis. And then the B is the linear stapling device, typically used for end-to-end, side-to-side anastomosis. And then C is a stapling device typically used to seal up cut edges of the bowel. We can see a pictographic representation using the circular stapling device technique. And then the patient is in the lithotomy position. A pulse string was actually applied to the proximal segment and the distal segment. So after advancing it, it was secured before the gun was shot, and opposed the both edges together. In the postoperative care, this is also important for success outcome in your bowel anastomosis. It is advocated to keep the bowel and the patient on nil pause for about 5 days, as the bowel is trying to undergo the various phases of bowel healing, typically the inflammatory, the proliferation, and the maturation stages of bowel healing. And then it's advocated to also put an NG tube to aid in decompressing the gut, because the different parts of the gut, so despite the patient being fasting, still secretes various amounts of fluid, starting from saliva to the gastric fluid, to the bile, to the stomach, to the intestines, as well as the pancreas. So there are the gut generally secretes about 8 liters cumulatively daily. So passing the NG2 can aid in decompressing the pressure on your anastomotic site. However, in some cases, intraoperatively, depending on the site of anastomosis, to aid in this decompression, you might have put a colostomy to protect your anastomotic site. Also, adequate IV fluids is paramount, as this ensures proper blood supply and perfusion of your anastomotic edges, as we had noticed earlier that it's an important factor to promote bowel healing and recovery. Also, use of antibiotics, both prophylactically and preoperatively, has been advocated to promote outcome, and then postoperatively for up to 48 hours post-op. Also, adequate analgesics will also help aid in mitigating the metabolic response and the inflammatory phase of this bowel anastomosis. Also, early ambulation of patients has been noted to significantly improve outcome of patients who have undergone bowel anastomosis. So in general, the factors that affect anastomotic healing can broadly be classified into the patient factors and then the technical factors. Technical factors include both the the technique, and then the method of the technique, and then the various factors involved. And for the patient factors, it could include old age is advocated. People who are older did not heal as fast as the younger ones. Malnourished patients, as I said earlier, preoperatively, it has adverse outcome for anastomosis, because the bowel are slim and they've lost, they are not as thick as they should, because there's chronic wasting. So the integrity of your anastomosis is already compromised. Also anemia, because we need adequate supply of oxygen to the cut edges to promote wound healing. And presence of comorbidities, all these such as chronic liver disease, chronic kidney disease, and diabetic mellitus have also been noted, and also uremia too have also been noted to affect anastomosis, bowel anastomosis. Also, typically, the use of steroids reduces wound healing. Smoking, advocated that elective cases, smokers should stop at least 4 to 6 weeks before your surgery, and also 6 weeks after. They shouldn't smoke, as this significantly has an impact on the bowel anastomosis. Also, prior history of radiotherapy, as radiotherapy would have affected the integrity of their tissues. So it advocated that patients who are undergoing resection anastomosis for various indications, such as malignancies, should wait for at least 4 weeks before where tissue regeneration and healing has occurred, before you reapproximate the bowel. And then, depending on the nature of the pathology, also affects the outcome, and also the site of anastomosis, as small bowel anastomosis has been noted to have better outcomes as opposed to the coloanal anastomosis or ileoanal anastomosis or esophageal anastomosis, which have higher leak rates. Now, for the technical factors, these are intraoperative and surgeon factors. Poor blood supply, for whatever reason, will significantly affect your anastomosis. Twisting of the mesentery at any point in time. Repair under tension will affect your anastomotic site. Mesenteric hematoma will also affect your anastomotic site. Inadequate seromuscular apposition significantly affects, because this might lead to anastomotic leak and fecal contamination. Distal site obstruction increases. If there's a distal obstruction, it has to be released, as this increases the pressure on your anastomotic site, therefore predisposing it to leakage. And fecal contamination will also increase the amount of inflammatory response and also promote bowel leak. So typically, the common complications we see from this can be the early or late. In the early complications, we can see bleeding, we can see anastomotic leak, sometimes wound infection, surgical site infections, intra-abdominal abscess, obstruction from if the anastomosis, the bowel segments that have been anastomosed as stenosed, and then stricture in the long run, and then prolonged hilus are some complications we see following bowel anastomosis. Now, there are some controversies for the various types and various principles that we use in bowel anastomosis for whichever one is better and which one should be advocated. There are various studies that have been done across various fields to show which is better. Now, for the inversion of the edges or eversion, for typically most surgical techniques, the single layer, the ceromuscular layer involves adequate mucosal occlusion and inversion of the cut edges. However, the stapling techniques typically uses the eversion when it is the cut edges are opposed. However, the different studies for inversion, and the pros for inversion is that it allows adequate mucosal apposition, and then it ignores accurately opposing clean cut edges for that. And then for the eversion, however, for inversion, there's the risk for bowel stenosis, that is your luminal stenosis, so it reduces the diameter of your bowel. However, for the eversion, greater anastomotic strength, less luminal narrowing. However, there is greater chances of, it has lesser hemostatic effect. Also, the use of the NG tube, there are different studies, both retrospective and prospective studies that was done, showed that the routine use of NG tubes actually provided no significant advantage, as irrespective of how much, as we mentioned earlier, that different parts of the digestive tract actually secrete different fluids. So as much as you are still decompressing the bowel with the NG tube, the other parts are still trying to pass and still actually pass your anastomotic site, irrespective of how much you try to, and because the intestines still have their own secretion. However, there was an increased incidence seen for respiratory tract infection for those that had NG tubes because of the use of NG tubes. So it was seen that it was related to more morbidity. Now, for the hand sewing versus the stapling technique, a study done by Anthony Brilliant, Tino et al. In 2023 showed no statistically significant difference in anastomotic leak rates of the two types. That's both the hand sewing or the stapling anastomotic technique, either using the circular or the linear stapling devices. So it showed that there was no statistically difference in anastomotic leak rates of the two methods. Hence, you can choose to use either the hand sewing or stapling based on the availability of these equipment at your site center. So also for the single layer and double layer technique, currently there's no evidence to support the superiority of any of this anastomotic technique. That is either the single layer or the double layer. And this is backed by a study done in 2020, which revealed no statistical difference in anastomotic leak rate using the single layer technique or the double layer technique. Now, the routine use of mechanical bowel preparation for elective cases has also been guided, has been said to be should be abandoned, as a recent meta-analysis of 14 randomized controlled trials actually suggested that mechanical bowel preparation does not prevent surgical site infection and should be abandoned in clinical practice. However, a recent analysis of surgical care improvements suggests that oral antibiotics preoperatively reduce postoperative wound infection, especially if bowel preparation is not used. Hence, the routine use of mechanical bowel preparation is not advocated. Also, the use of abdominal drains typically seen for pelvic surgeries. Study revealed that the use of prophylactic drain did not significantly improve hospital stay or outcome for these patients. In conclusion, extensive knowledge on the principles guiding bowel anastomosis is actually paramount for good outcome and reducing the morbidity associated with complications from poor anastomosis. Accurate approximation of two well-vascularized healthy limbs of bowel without tension in a normotensive, well-nourished patient almost always results in good anastomotic outcome. Thank you. These are my references.
Thank you very much, Dr. Samuel, for the presentation. We've all listened to you. It's now time for comments, questions, and contributions. So I've seen some comments and questions on the chat box. So I think let us start with these questions that are dropped in the chat box. Then before we now entertain those who will make their comments, observations, and ask their questions. Our chief, Dr. Solomon, is asking, he made an observation. The first point, PCV is in percentage, not in grams per DL. You meant HP, I guess. So it's a mistake. There's an observation. Maybe you made a graphical error. So you take note of that and correct. Then second question that was asked, is it all part of the bowel, small and large bowel, that requires more preparation? So you can answer that.
Okay. Typically, it's when we are doing resection and anastomosis of large bowel, because that we typically do the routine bowel preparation. However, as I said earlier, that practice, studies have shown that practice has no significant improvement in outcome of anastomosis for mechanical bowel preparation.
Is it all part of the large bowel you do bowel preparation?
No, it's typically the left side of the bowel, as this is largely because of the microflora. The large bowel actually has more microflora, so we are trying to reduce the bacterial load in the large bowel, as it's quite higher, especially at the the left side, which becomes typically solid. The fecal content becomes more solid, and the bacterial load is also higher at the left side of the large bowel.
Okay. So the next question here is, okay, what do you mean by cheating or chittling?
Okay, by chittling, we mean typically when the caliber of the cut ends of your bowel are not approximate, are not the same. A way in which you can increase the diameter of the smaller segment is the chittling, which involves typically you slit the antimesenteric border of the smaller bowel to tend to increase the diameter of the anastomotic edge, so as to be able to approximate them together.
Did you have any diagram to demonstrate all this?
For chittling, no, I didn't have for chittling.
What do you mean by cheating?
For cheating, it involves taking bigger bites from the small. When you take from the smaller lumen, the smaller diameter to be anastomosis with the bigger diameter, you take a bigger bite from the bigger one. So you are not taking equal bites from both sides.
What do you mean bigger bite from bigger diameter? Where you have disparity in the lumens, you are anastomosis. Is that what you mean?
When you have, typically when you have disparities in the diameter of the bowel to be anastomosed, first you can do the chittling, and then you can also try to approximate them together.
So what do you mean? What is cheating?
For cheating now, when you take a bite from the smaller mucosa, you try to it's not at the same parts. It's not be perpendicular. Your bite is not perpendicular. You take a bigger bite from the larger diameter bowel and smaller bite from the smaller diameter bowel cut edge to be anastomosed.
Okay, we will still listen to comments. I'm just seeing how you respond to all the questions first. How will you ensure that the bowel is viable intra-op? That is another question on the chat box.
Okay, so typically when you are resecting your pathologic ends of the bowel, when you're anastomosing, after resecting it, you try to look at it for active bleeding and color change. So you look at the color between the viable bowel and the non-viable bowel. That's one way to look at it. Also, the bright red blood from the cut edges is also an indication of viability of the bowel intraoperatively.
Sorry, must you cut the bowel to know that it's viable?
Before cutting, the color of the bowel, if it appears darker as opposed to the others that are more pinkish, that's an indicator that this part might actually be pathologic.
So color, yes. One is dusky, the other one is pinkish. Yes, what again?
Another way is if you apply your diatemy, you can see the muscular contraction for the viable part, and then the non-viable part, actually the muscles does not contract.
You want to apply diatemy on the bowel just to confirm viability? No, that is not correct.
Or if you actually try to touch it, if you actually touch that, the bowel, the viable one does not it does not contract. The muscle there does not contract. However, the viable one actually contracts.
So if you tap, well, I think what you are trying to say, if you tap a bowel, if it is viable, there will be visible peristalsis. Is that what you are trying to say?
Yes, some form of peristalsis, yes, sir.
So if it is not viable, there will be no peristalsis. Yes, what again? But sometimes, patient might be peritonitic and the exudative infected fluid might cause ileus, where you won't see any form of peristalsis. What else will you use in confirming viability? Yes, you've mentioned two.
We can also use, I don't know how to put it, the use of devices to actually show electrical input.
Not device. Don't stimulate any electricity there. What do you want to look at? What is the evidence of blood supply to that bowel?
One is the color, and the temperature also, or the
No. You look at the mesenteric pulsation, the mesenteric vessels that are supplying the bowel. When there's pulsation, there is also another. Well, we'll leave. Let's finish the questions on the chat box, then we'll come back to the discussion. I think the next question is, good evening, sir. How do you check for leakage intraoperatively? Yes, that is another good question.
Okay, to actually check for leakage intraoperatively, one way is actually to try to milk intestinal contents from the proximal segment through to see if the contents actually pass. To see if the contents actually pass to a distal segment.
Okay. Okay, what if there is no sufficient content?
Another way that was advocated is to actually try to put the anastomosis segment inside in warm water, and then sometimes to actually try to put insufflate air to see if there's bubble.
Insufflate air through air?
the anus.
Serious? Where did you see such a thing?
I saw something like that in one article I read, but that's why I didn't bring it up. I'm not 100% sure. I'll check again to be sure. But I think they typically use it for pelvic surgeries. During pelvic surgeries, after anastomoting the edges, they put it in water to see if air actually passes.
I think you shouldn't mention something like this in an exam. They will just say you've not been practically attending anastomosis surgeries that are involving anastomo. What if it's in the small bowel?
Okay, so another way to see if to make sure that your anastomosis is actually watertight.
Okay, the next question on the chat box is, good evening. While studying, I come across a sentence, the redesigning of the angle of sorrow. I need clarification.
Okay, for the angle of sorrow, uh, typically, I know that the angle of sorrow are the angles that are usually predisposed to more anastomotically. That is the antimesenteric border and then the mesenteric borders. So when reading, I think I came across the fact that you typically use at the antimesenteric and mesenteric borders is actually better to use the cornell stitching technique to navigate those edges, actually to reduce the rate of anastomotic leaks at these angles of sorrow.
What is the angle of sorrow to start with?
Okay, these are the edges of the anastomosis that are actually predisposed to greater risk for anastomotic leak. The corner of the anastomosis that's during anastomosis, the corners that are predisposed to greater anastomotic leak.
Is it in all types of anastomosis you have angle of sorrow?
No, it is typically seen in, I think, gastrointestinal anastomosis.
Okay, now these are some of the questions in the chat box. We will still come back to other questions that are placed on the chat box, but we'll now entertain comment from the audience as well as contributions and questions. Then we'll now come back to the chat box and answer some of the questions that are dropped there. So thank you. So if you have a question, comment, contributions, you can unmute yourself and go ahead, please. Thank you.
Okay. Good evening, everyone. Thank you,
Magaji.
Dr. Sam, for the presentation. I'm Dr. Magaji, Registrar in Surgery Department, FMC Abuja. Just some few contributions. Now, while applying clamp before resection, the clamp should be applied at about 30 degrees. Now, the reason why you're applying this clamp is to control spillage at the operation site. So there are two clamps you apply. The crushing one, which is on the site of the resected bowel, while the occlusion clamp, that is the non-crushing, should be on the side of the variable one. Now, after application and resecting this resected part, you can actually decompress the bowel using your suction, which will now allow you to unclamp to allow blood to freely flow so that you can actually observe the edges of your bowel, which you want to anastomose. Then, secondly, I've talked about the visualization of the mesenteric arteries and palpation of the arteries to confirm actually the ends you want to anastomose are actually perfused by the blood from the mesenteric arteries. Now, the suture, the distance of suture you are going to apply, you didn't mention the actual distance, even though it is quite difficult to estimate it. Yes. From the cut end, you're actually to apply it 0.5 centimeters from the cut end. Then the distance between two sutures should also be about 0.5 centimeters in an adult. So I don't know for the measurement in children. Maybe you can tell us that. Then the reason why you are picking muscularis mucosa is not to improve outcome postoperatively. It is actually the part that has the strength in the bowel. So if you don't pick that during your anastomosis, there is risks of anastomotic breakdown. So that's the main reason why you pick the muscularis mucosa.
Okay, thank you, Dr. Magaji, for your comments. Now, when you say 30 degrees, what do you mean? You said the clamps are applied 30 degrees.
Yes, that they are slanted about 30 degrees. It should be in an oblique fashion.
30 degrees to what? So that will be clear.
From the antimesenteric border.
Okay. So it should form 30 degrees.
At the mesentery.
Okay, at the mesentery.
Yes.
It's still not clear.
Okay, so one will apply the clamp obliquely from the antimesenteric border towards the mesenteric border.
So you are
inclined at 30 degrees.
Okay, you are applying a clamp 30 degrees. Okay. You are applying.
Yes, sir. Coming from the antimesenteric border towards the mesenteric border, slanted that way.
Okay. So any other comments, please? You can unmute yourself and ask. Questions, comments, contributions, please. The floor is open. Okay, I think there's another comment on the chat box. Good evening, all. In addition to cheating and cheatling, the large caliber bowel may be resected transversely, while the small bowel resected obliquely. Yes, this will create a comparable lumen for anastomosis. That is a contribution there. Okay, it appears there are no other comments or questions from the audience. So let me make some observations, Dr. Samuel.
Hello, Chief Bashir.
Okay, Amashel, you can go ahead, please.
Good evening, sir. Thank you very much for the opportunity. Dr. Samuel, thank you very much for the wonderful presentation. It was a very good attempt. I was very impressed. But I just have some few comments to make. I saw the way you discussed the post-op care, early ambulation, antibiotics, analgesics, and oxygen administration for some patients. I was very impressed with that. So the suggestion I have for you is that you can summarize that in case you don't have a lot of time in an exams, and say activation of the ERAS protocol, enhanced recovery after surgery. Yes, that will, because all these things, they fall under ERAS. Then again, it is also important to also mention almost all these things in the preoperative period, even though I heard you mention bowel preparation and you mentioned bowel and then adequate hydration, which is also correct. Then some of our patients that have proximal stomas, particularly those with ileostomies, a lot of them are at risk of some fluid and electrolyte derangement. That we should take note, and it is likely because of the proximity of their stoma. But those with colostomies, those that have stomas that are quite distal, they more commonly don't come down with fluid electrolyte derangement for obvious reasons, isn't it?
Yes, sir.
Because the stoma is very far, absorption takes place, all the fluid electrolytes
Proximal.
are absorbed to a significant amount. Then the other thing also, which you mentioned in the complication and then the factors affecting, is malnutrition. Sorry, nutrition. You mentioned nutrition as an important factor in the treatment. So it's also important to mention in the preoperative preparation of these patients that in the setting of malnutrition, that you will have to do adequate nutritional rehabilitation for the patient, particularly for patients that are going for elective anastomosis. Then the other thing that I found a little strange, even though I know that has been the teaching for quite some time, is the fact that you want to keep your patients on nil per hour for 5 days. I saw that on one of your slides.
Yes, sir.
So I don't know where you got that, but yes, for our professors and the older colleagues, that was the teaching. You keep the patient starving for days. But if you check the literature, particularly in Baja, you will discover that small bowel peristalsis return within 6 to 12 hours, and then followed by the stomach, and then followed by the colon. And within 24 to 48 hours, almost the whole of the peristalsis in the gastrointestinal tract is back. And if you remember the secretions in the stomach, in the biliopancreatic tree, and the succus entericus, you discover that even within the first 24 to 48 hours, gastrointestinal secretions are actually passing across your anastomosis. So if that is the case, then why stay up to 5 days? Then also a research was conducted in Zaria by one of our senior colleagues. I think they call him Dr. Ajaga. Dr. Ajaga SO. I think maybe you check the literature, you see it. He discovered that almost all gastrointestinal anastomosis, after 48 hours, you can actually commence the patient on greater oral use. He made that research. I think that was Africa or national. I can't remember which one, but he conducted the research and actually found out that you can actually commence safely, and the patients did very well. So we no longer starve our patients. In fact, in Zaria, if you leave a patient beyond 3 days, anything beyond 72 hours, it becomes an issue. People will start asking you, what are you waiting for? Because it has become normal. So that is the take home in that part. Then in the complication, I like the way you discuss them too. However, the leakage can be in different forms. There can be complete dehiscence, which means the whole of the anastomosis has given way, which is a catastrophe for us as general surgeons. We don't like that, and we're not happy with it. Then the other one is that those angles you are trying to describe, one or two of them can leak. So you have partial leakage now, or so that's the leakage you are describing, where it will be some leakage, it will leak into the peritoneum, then it will be contained, and then in most of these cases, it resolves spontaneously because once the patient is managed properly, that those small leakages, 1-2 centimeters, they will heal without much problems, except for maybe the collection that will collect in the abdomen, which will later give rise to intra-abdominal abscess, which can be drained percutaneously. But most of them, once the volume is not much, the body can absorb it, and then it will be self-limiting. Then the other thing that it's also advised is that intraoperatively, you mentioned issue of not applying clamps on the mesenteric vessels. It is also advisable that those clamps that Dr. Magaji was describing, yes, they can be very good in controlling spillage. But again, if you can do without them too, it will be very good, because they've been found out that applying them can also increase the risk of necrosis and then, sorry, ischemia and then necrosis. Then the other thing is that, when you're refreshing the edges, particularly when you are reversing stoma, you discover that the edges will now start bleeding profusely. It's a good sign too that that portion of the bowel is viable. However, as much as possible, try to resist putting very powerful clamps on the edges of the bowel. But if bleeding is significant, then you can actually clamp briefly, either 1 or 2 clicks before your suturing gets to the location of the blood vessel. So these are some of my complications. By and large, thank you very much for the presentation.
Thank you for the comments. Thank you, sir.
Thank you very much, Dr. Ahmed Shehu, for those wonderful comments and contributions. They are really insightful. I hope, Dr. Samuel, you took note of all those.
Yes, sir. I'm jotting them down.
Okay, that is very good. So we'll entertain more comments, contributions, and questions, because the more the comments, the richer the presentation, and the better our take-home messages. So if there are other comments, please, you are free to unmute yourself and go ahead. You can ask questions, you can make contributions.
Okay, thank you, sir. I have a question.
Okay, go ahead.
But the suture materials used in focus on the mention that one can actually use non-absorbable, but I've never seen any surgeon use non-absorbable to do bowel anastomosis. But I saw it in the text. So is it possible?
Thank you.
Is it possible for us to be using the non-absorbable?
So when I actually looked, I also saw it in the literature. So they said yes, it's possible, especially at the 2-layer anastomosis method. You use the absorbable for inner layer and then the non-absorbable for the outer layer. That's what I saw in the text also. But I've also not seen it being practiced. That's why I didn't mention it so much. I mentioned it in passing, but I know typically we use both the absorbable if we are doing the 2-layer method, we use absorbable for the 2 layers. I think that practice, I don't know, I think is no longer routinely used.
Which type of non-absorbable did you see?
I think they mentioned, I'm not sure, sir. I'm not sure. I don't think they mentioned the exact type.
Dr. Magaji, what non-absorbable did you see? Yes?
It was not, the specific type was not mentioned.
It's silk. It's silk. They are not talking about nylon.
Okay.
Yes, you
still break down.
And you can use silk. Silk is you can use it for a seromuscular anastomosis. You see, one observation, some of the observation I make in your presentation. One, your images. You see, sometimes the reason why I was just asking some of the questions, not that because they are not very clear, but they will have been clearer with good images.
Pictures.
Yes, when you have pictures, diagrams that are illustrating, okay, you say few words in describing or in passing the message. There are so many things you were describing during the intraoperative techniques where a single image will have covered a lot. Okay, so that is one observation which you need to work on and add some images to your presentation. Okay?
Okay, sir.
Yes, that is one. Then secondly, healing of an anastomosis is completely missing in your presentation. You see, all the principles of delaying oral intake revolve around understanding the phases of healing in anastomosis. You know, there are three phases. After you do a Bowel anastomosis, it undergoes the early phase of 0 to 4 days. Okay. In fact, some of the early phase of acute or the acute inflammatory phase can even occur in just 2 days. Then you see some surgeons, even if it is a large bowel anastomosis, they can even commence their patient after 24 hours. So the early phase, which is the acute inflammatory phase, okay, there's an intrinsic cohesion between the mucosal lining of the bowel you anastomose. This takes place within 0 to 4 days. The next phase is the phase of fibroplasia that ranges between 3 to 14 days. You have fibroblastic proliferation, and deposition of collagen. And it is at this phase you have strengthening of the anastomosis. Okay. And lastly, after 10 to 14 days, you have maturation, where there is the remodeling of the collagen that has been deposited in the line of stress or peristalsis. So these are the phases of anastomosis healing. So this forms the basis of not why will you delay patient for up to 5 days to worsen the malnutrition. Any patient that is going to be on MPO for up to 5 days, 5 days to 7 days should be on TPN. Yes, on parenteral nutrition. There is no reason for, after all, if you take, if you look at the pattern of fluid absorption in the intestine, how long does it stay in the stomach? Okay, most absorption will take place in the jejunum before it gets to where even likely your anastomosis is. Okay, so there's no reason for delaying. And exteriorization. Now, in what situation will you want to just exteriorize a bowel? You don't want to anastomose. Yes?
In situations such as gross fecal contamination, it might be advocated to just exteriorize the bowel as opposed to primarily anastomosing it.
Yes.
And then, sir?
You wanted to add something, yes?
Okay, so then it's also advocated for large bowel anastomosis, and ileostomy too can be done to promote anastomotic healing and then subsequent reversal, especially after resection after malignancies.
In some emergency procedures where a patient is unstable, okay, a critical issue where you have generalized peritonitis with gross fecal contamination or abscess collection, okay, there's purulent collection in an unstable patient. One, you don't want to waste time in anastomosis. Two, you don't want to do site anastomosis in a grossly contaminated abdomen. Do you understand? So that's in that situation, you just want to exteriorize and continue resuscitation. When patient is more stable, you come back for anastomosis. Because in those situations, when you do anastomosis, okay,
Yes, sir.
break down, and patient will come up with tertiary peritonitis. Okay, that is the breakdown, post-operative peritonitis, leakage from your anastomosis. Secondly, when there is gross edematous bowel, if you do anastomosis, when the edema subsides,
It's really good.
yes, the suture will now loosen, because when you were applying the sutures in a grossly edematous bowel, okay, at
Yes,
that
sir.
point in time, the suture will be well fitted. But after inflammation has subsided, what will happen? The edema will subside
Edema.
and the sutures will become loosened, and your anastomosis will start leaking. Okay, and this issue of clamps, okay, you did not tell us, though Magaji mentioned some technicalities of clamps. You know, there are two types of clamps. You have the crushing clamps and the non-crushing clamps. So now, how do you differentiate a crushing clamp from non-crushing clamp?
For the crushing clamps, the inner margins or the inner aspect of the clamp is actually serrated, and there are some protrusions. However, for the non-crushing clamps is smooth. The inner aspect is smooth.
Well, even in the non-crushing clamp, they might be serrated also. But what is the difference in the serration of
It's
crushing and non-crushing clamp?
uh,
Is
I'm not
the
sure.
depth, is the
Crisscross.
depth of the serrations.
Okay.
Is the depth of the serrations.
Depth of the serration.
So Amashewu was even discouraging, because of sometimes you can just cause too much injury and even devascularization. So that's why the portion of the bowel you are applying the crushing clamps should be what at the segment to be resected, okay? They completely occlude the lumen and prevent spillage, while the non-crushing clamps are applied outer, okay, to the crushing clamps, and you give space for resection. Now you should note, when applying the non-crushing clamp, you know there are several clicks on the ratchet. You shouldn't click completely. You understand? Because if you click the 3 or 4 steps of the ratchet, it becomes a crushing clamp.
Yes, sir.
You just occlude the lumen. The role of the non-crushing clamp is occlusion of the lumen. So just the first step is enough, okay? The first step is enough. You must not apply the 4 or 3 steps of the non-crushing.
Gotcha.
While for the crushing, you can apply all the steps, because you want it to be well fixed even after division of the bowel. It is so fixed that you will not have spillage of the contents of the resected segment. So these are things that you should project with images or diagram for better understanding, and the orientation of the clamps, the way they are. In fact, they are named clamps. What is a named crushing clamp, you know? A common crushing clamp that is used for gastric resection.
I'm not sure, Chief.
You see, this is where all those diagrams and images come in. There's the Payer's clamp. Okay, have you seen the Payer's clamp before?
No, but I think I actually saw something like that, but I've not seen.
Look at the Payer's clamp. You should look at the Doyen's clamp, the non-crushing clamp. They are different types. They could be curved, they could be straight, they could even be angulated. Okay, so there are different shapes. Their serrations have different. You have straight, you have oblique, you have longitudinal, different types of clamps, Coca's clamps. They are named, so it is important when preparing for this kind of presentation, you are conversant with all the devices that are used. In fact, there's a textbook of operative surgery, Zollinger Atlas. I don't know if you've come across that textbook. Zollinger Atlas of Operative Surgery. If you use that book in preparing for a presentation like this, you have a lot of images. It's an atlas for operative surgery. Okay?
Yes, sir.
Yes. So that is very important. But by and large, you did well. You tried, but there's an area you need to make an improvement. That is area in terms of the way you respond to questions. Now, responding to questions in surgery requires organization and precision. Okay?
Yes, sir.
And thirdly, you must use the trade language. If you don't know how to respond to questions, you will be in trouble. Even if you know, the examiner cannot search your mind and bring out the answer. Most of the time, there are some questions that you are anticipating, and you have to organize and package the answers, and you learn how to deliver the answer. If not, if you are asked as simple as asking how to confirm the viability of a bowel might be difficult for you to answer, because you know definitely if you are to present bowel anastomosis, any examiner must ask you this question. Now, if it is not viable, what will you do? For example, you see a bowel that looks dusky. You are not sure if it is viable or not. What will you do? Yes?
If I see that it appears dusky, I can apply a warm gauze pad over it for a while and see if the color changes after that. And then I can also check the mesenteric vessel, supplying that for pulsation, supplying that segment of the ball for pulsation around it as a guide.
Okay, you apply a warm saline soak pack, because if you just say warm pack, it doesn't pass a message. Then what else? Yes, for how long? And what must you ensure from the anesthetic side?
Okay. From the anesthetic side, I'll have to ensure that at that point in time, the patient's blood pressure is optimized. The blood pressure is okay. And
the blood pressure, you are concerned.
The oxygen saturation too.
Oxygen saturation, okay? The oxygenation should be 100%. Okay, the oxygen flow to tissue should be optimized to 100% while you apply a saline soap pack over the suspected ischemic bowel, or the bowel that looks dusky. When it's dusky, it's losing its luster. Okay, so you now wait for about 5 minutes or even up to 10 minutes. Okay, then you now look at it. If there's viability, it will become what? Pink. When after that, the patient and the bowel still looks dusky and flabby, okay, you know that this bowel is not viable. The patient, you give a one pack that will improve circulation, the oxygenation is improved, and you allow for some time. and that bowel still look flabby and dusky. Recently, I had a patient that is still on admission. He came with mesenteric vascular injury. Surprisingly, it was following a blunt abdominal injury, and there was compression of the mesentery, okay? The small intestinal mesentery against the posterior abdominal wall, against the vertebra. When we open, there's contusion there, and about 90 centimeter of his small bowel was dark already. So you can imagine. So after resecting, though we won't go into that, it's not the topic for discussion. What was left was significantly short. So we have to ensure that segment is viable before coming out. So that is you will see a lot of challenges like this. And if you don't know what to do, it might be really difficult. Now, the specific types of anastomosis, the single layer, what is the name?
That's single layer seromuscular.
Yes, what do you call that? When you do interrupted simple or outer layer, what is it called?
The Lambert stitch technique.
Okay. The continuous inverting technique, what is it called?
It's the Cornell technique.
Cornell technique. Can you tell us the sequence of the Cornell technique? The common technique we use. So that you just be singing so that you don't forget.
Yes, sir. Okay, so for the sir?
Yes, for Cornelling technique, what is the sequence you follow? The continuous inverting suturing technique.
Okay, so this sequence is the inwards.
Use mucosa and serosa.
Okay, so you start from outward from the serosa to the mucosa on the same side, and then that's outward in.
So
And then from
just mention the sequence. No matter how you are going, if that sequence is correct, it's going to tally.
Okay, the form of horizontal mattressing.
You don't understand. Just say mucosa, serosa, serosa, mucosa. Okay. The sequence.
Yes, sir.
So tell me the right sequence.
Okay, it's from. Okay, the right sequence is from serosa to mucosa, mucosa to serosa on the same side before going to the other side. Then from the other side, you start from serosa to mucosa, mucosa to serosa.
Yeah, so that is the sequence. So anytime you are doing a coloring technique, just have this at the back of your mind. You are not going to get lost. And secondly, another technical thing you should do when when citing an anastomosis, you should never allow bulging of the mucosa. Is that clear?
Yes, sir.
Anytime mucosa is bulging from an anastomosis, the fluid will find its way to leak out through that mucosa and you have leakage. So ensure whether you are doing a single layer or a double layer, ensure the mucosa is not bulging out your line of anastomosis. That is a cause of leakage. Okay?
Yes, sir.
Your anastomosis should be tension-free. Okay? Your anastomosis should be tension-free. Don't forget that. Yes. Any other comment? Now, there's one technical thing again when you are creating a mesenteric window. Okay? Maybe I have to draw this for you because you don't have the image there. Okay? Let me see if I can put a white a whiteboard and draw something for you so that you understand can you see my whiteboard?
Yes, sir, we can see it.
Okay, now, assuming this, I just want to demonstrate something, but unfortunately, it appears as if it's not really. Okay. Can you see my whiteboard?
Yes, yes, sir, we can see it.
Now, you know when you are making anastomosis, assume these are the vessels that are supplying the bowel in the mesentery, okay? And you want to take off this segment. You want to take off this segment up to this root like this, okay?
Yes, sir.
Following?
Yes, sir.
Now, what you need to do, if you are dividing this place, okay?
Yes, sir.
You have to shine the mesentery against light so that you see the distribution of the vessels. As you are putting your artery, you don't injure the vessels. When you insert your artery here, you make a transverse opening, okay?
Yes, sir.
You go above it, make another transverse opening like this. You see, you have two transverse opening, then you now place two arteries longitudinally like this. Then you cut in between, it will give you a space. Is it clear?
Yes, sir.
I don't know whether that is clear.
Yes, sir, it's clear, sir.
If you want to go above, you make another transverse opening with your artery. Then you apply your clamps longitudinally. You just notice that you are getting a very straight line of dissection. At all these points, you'll be using your sutures to tie if they are blood vessels. So let's say there is a lesion here. At this point, you want to maybe divide this. What you do here, make a transverse, make another transverse, okay? Then you put artery here, you divide, it will create a window. That is when you are creating a window on a mesentery. You insert your artery, make a transverse opening, make another transverse opening. Then you now apply your clamps and cut in between. It will create a window. Is it clear? So
yes, sir.
You will follow that technique up to the extent of the bowel you want to resect. Then you now apply whatsoever you want to apply and resect the bowel. So there are so many things that are practical when, if you are in the theater, you should ask the senior registrar or you ask the consultants to demonstrate some certain things. They are better demonstrated than read in the text. So those are some of my comments and contribution. But this, by and large, is a very interesting and a very important topic for all general surgeons. Okay, whether you are using hand-sewn anastomosis or using instruments, staplers, another category, you need to understand the principles they work. So thank you very much, everyone, for participating and sharing your thoughts. and contributions. So we are going to announce the next presentation in the group subsequently, and the link will be shared, God willing. So in the absence of any contribution, we want to stop here. It's already 10 p.m. past 10. So if there's comments, you can briefly make, but if there is none, we will have to stop the presentation here.
All right, thank you so much, Chief, for enlightening, for this real in-depth enlightenment. I've really learned a lot more. Thank you so much, Chief.
Okay, you are welcome. So thank you very much, everyone, for the for participating in this week's presentation. God willing, next week we are going to continue with the presentation. Thank you all.
Oh, thank you. Good night.